So we are starting with an interactive case. So it's a case scenario, and gradually we will treat this case and we will discuss all the issues appearing while treating and diagnosing this patient. So ours is a 30-year-old female, housewife with 3 kids without any addiction, is presented to OPD with complaints of cough since 40s. This is dry cough, the low-grade fever, loss of weight, which is 5 kg over 1 month. She is diabetic since last 3 years, and there is no prior history of tuberculosis. There is no history of any contact, and socioeconomic status is good. So, first question: what are the common symptoms which suggest pulmonary tuberculosis? Most common symptom which you see in cough. Very good. What else? Weight loss. What else? Fever. Anything else? Hemolysis? Joint pain? Nothing? Night sweats. Very good. So this question will be answered by Dr. Hariana.
So yeah, as most of you have said the symptoms correctly. So cough and fever, which is predominantly there for a prolonged duration, as you can say, more than 2 weeks, are the suspects which have to be screened. Along with that, appetite loss and weight loss, these constitute constitutional symptoms which we should look for. And if there are parenchymal lesions like cavity and all, you can have hemolysis as well. And sometimes in extrapulmonary TB, like if you just have a pleural effusion, you can have chest pain as well. So these would be the common symptoms which you should look for.
अभी ये symptoms सारे बोले हैं they are all standard symptoms of tuberculosis. हमारा जो 2019-2021 में सर्वे हुआ है TB prevalence सर्वे 40% लोग ऐसे थे जिसमें से पूरा ये पिक्चर नहीं था. किसी में खांसी एक दिन की थी या एक एपिसोड था, बुखार भी नहीं था, वेट लॉस भी नहीं था, हिमोसिस की बात छोड़ दो, कुछ नहीं था ऐसा. 40% people when they were subjected to X-ray, there was abnormality and they were subjected to MAT testing, molecular testing, and they were found to be suffering from pulmonary tuberculosis, not having these cardinal signs. And 50% of those were found out to be are ampicillin resistant. उनका आगे क्या हुआ फर्स्ट लाइन सेकंड लाइन में we don't know. आगे हो रहा है. But though these are guidelines and the program says these are the signs. But for me, I always say you have to move from the highway. This is this highway. If you have to find more cases, then even one episode of cough should be suspicious and should be investigated for only one episode. हमने भी देखा ना, हमने आपके पॉलिटिक्स में देखा है. एसएससी हुआ था लास्ट ईयर. ये पिछले साल फरवरी की बात है. पहले मैं हार्डवेयर गया था, नेशनल आईआईटी वैली, तो 2 वर्कर देते हैं नेशनल सर्टिफिकेशन. तो आई विजिटेड द हाउस. द लेडी 65 year लेडी, शी कम इन फ्रंट ऑफ मी. हमने उससे पूछा ये 3 वाली लिख के गई है, आपका सैंपल में लिया. कहते मेरे को खांसी आई नहीं, तो आपको देखकर आई. तो मैंने बोला अगर खांसी तो टीबी नहीं होती, हमने यही को सिद्ध करना है कि आपको टीबी नहीं है, ठीक है ना. तो हम आपके बगल की हम जांच करवा लें, करवा लीजिए. She got that tested and she came out to have ampicillin resistant tuberculosis. So even one episode should arise suspicion among the clinician that it can be tuberculosis and we have to rule it out. Thank you.
So these are the symptoms of the patient. So now, what is the differential diagnosis? What are the possible differential diagnosis on the basis of the symptoms? Pulmonary tuberculosis is very good. What else? Malignancy. IID can be there. What else? Pneumonia. What else? What else? Chronic pulmonary? Chronic. So it's a short duration, less likely to be chronic. What else? So, Dr. Nishant, please.
I think that the first answer was malignancy, someone said. That is very important. But then you suppose a 15 years old girl comes with this, then that should not be the first thing. A patient who is smoking and 55 years old, then you would consider it as the second lead in that person. So the risk factor should be seen, and in that context, you normally differentiate into as this chart says between infectious and non-infectious. So yes, malignancy and some chronic infections could be non-tubercular, NTM also, and fungal, parasitic. But then you have to be, it should match the clinical history. There is the connective tissue disorders and sarcoidosis, which very much mimics tuberculosis, and that is a very close differential, and it has to be looked at very carefully.
So it was both ways. From tuberculosis perspective, so if these diseases can appear like tuberculosis clinically, then TB can also look like this disease, and these diseases can also look like tuberculosis. So TB is differential when these diseases are suspected primarily. Now, what are the risk factors for development of tuberculosis in a specific patient? Immunocompromised, very good. Poor socioeconomic care. Diabetes, very important patient. Patient already had TB. So, Dr. Pankaj, please.
Yeah, I think most of the things are already being pointed out in this case, because if you look at this case, there are pretty good factors. But as mentioned here, there are two important categories which they define it as, the patient-related and the environment-related. Now, it's no longer a low socio-economic group. पहले तो इससे बाहर आ जाते हैं, ये बड़ी पुरानी सी कहानी है, ये तो पुरानी हो गई और मुझे लगता है बासी भी हो गई, अब नहीं बोलना चाहिए. ये लो सोशियो-इकोनॉमिक, एक तो हिंदुस्तान बहुत बढ़ गया है, तो हम बहुत, now we are no longer a developing country, we are a developed country. तो लो सोशियो-इकोनॉमिक वो केसेस में हम डालते जरूर हैं, बट सस्पिशन में नहीं आना चाहिए ज्यादा, बिकॉज टीबी किसी को भी हो सकती है, एंड इट हैज नथिंग टू डू विद दिस. लो सोशियो-इकोनॉमिक से मतलब बस ये है कि जो एनवायरमेंटल कंडीशन जिसमें वो रहते हैं, शायद वो ऐसी हैं जिनमें जैसे प्रॉपर वेंटिलेशन नहीं होगा, ओवर क्राउडिंग होगी, पॉवर्टी है तो मैल नरिश्ड हो सकते हैं, अच्छा खाना नहीं मिल रहा है, सो दैट इज समथिंग व्हिच इज देयर. सो इट कैन बी सीन इन दोस केसेस. जैसे इसमें और भी लिखा है कि पेशेंट रिलेटेड प्रॉब्लम्स भी हो सकती हैं, कि इम्यूनिटी किसी भी कारण से लो है, स्टीरॉयड पे चल रहे हैं, अगेन अ फैक्टर. सार्कोइड, ये सिलिकोसिस हमारे वाले बैच में बड़ी इंपॉर्टेंट है, बिकॉज इस पूरे एरिया में सिलिकोसिस इज वेरी इंपॉर्टेंट. So there is a co-TB infection, tuberculosis. And IV drug users, again, as they say that, किसी भी तरीके से immunity down हो रही है, because जब हम शुरुआत से देखते आए, infection, हम हमेशा से कहते थे there is two, one is infection, one is disease. तो incidence of infection बहुत ज़्यादा है हिंदुस्तान में. So कोई भी ऐसी condition जो flare up करा सकती है इस condition को, to get converted to disease. So I think most of the things are there. Yes, tobacco smoking, या क्योंकि इस केस में ऐसा नहीं बन रहा है, इस केस में ऐसा कुछ नहीं है, लेकिन हाँ, स्मोकिंग इज अगेन इंपॉर्टेंट फैक्टर. सो आई थिंक these are the factors.
So now we see there are quite a few risk factors in our patients for development of tuberculosis, right? Now there is one very important risk factor which is close contact. So now what is the definition of close contact? कितना नजदीक, कितनी देर, proximity and duration दोनों इंपॉर्टेंट हो गए. तो कितना आप क्या लगता है कितनी देर साथ में रहने से टीबी के चांसेस होंगे? 15 मिनट्स कितना दूर साथ वाले कमरे में? 1 मीटर। ओके, क्या आप बताओ? हाँ, 2 मीटर, मोर देन 15 मिनट्स। अगर हाउस होल्ड में नहीं रहता, बार बार आता है तो हो सकता है उसका नहीं होगा। So we clarify with Dr. Neeti. Dr. Neeti, please.
So, thank you, sir, Dr. Naveen. So, as most of you have rightly mentioned, that close contact means they are sharing the same space or they are near to the patient, and patient is sputum smear positive, active TB case. In that scenario, while eliciting history, it is difficult to elicit such a specific history. How far was the patient, how far were their contacts or their people living in house. So generally we would like to know whether they share same airspace, they stay under same roof, because there's a difference between family and household. Household also includes servants and other members. Generally we don't consider them as, when we talk ki patient say, we ask ki family mein kaun hai, so they may miss out. So you have to specifically ask for household contacts who are sharing the same airspace. And generally we consider 3 months duration. Last 3 months who have all been in their space. And I think other than household, slowly the evidence is developing related to workplace also. That who are in close proximity in workplace, they can also be included. When we talk for, when we are considering small children, and if the child is eliciting symptoms, especially less than 2 years. So in those cases, you have to take a more longer history. I think it is ranging from 2 to 5 years, 2 years specifically, for a pediatric age group, that in last 2 years or 1 year, if he has been in close contact with any TB patient. So it is essential while taking history of patient to elicit close contacts. Thank you.
Thank you. And now the patient was underweight, rest of things was normal, there was 100-degree fever, and there was hemoglobin was low. So now what are the hematological abnormalities which might be there? CBC is one investigation which we do in almost all patients. So हम क्या क्या इन्वेस्टिगेट, क्या क्या abnormality हो सकता है जो उसको देख सकते हैं? ESR related, okay. Anemia, very good. कौन से तरह का एनीमिया होगा? Macrocytic, हाँ, microcytic, okay. Dr. Gopal, please, can you elaborate a bit more?
I think we can see all kind of pictures in hematological findings, leukocytosis, neutrophilia, but these are not diagnostic, I must say. We are not going to diagnose based on these things. What we commonly see is definitely ESR is elevated and there is thrombocytosis. Very often in the wards we see patients with tuberculosis with marrow suppression. So these patients may have microcytic anemia also, and normocytic normochromic anemia is also seen in these patients. So thrombocytosis, elevated ESR, it is not that leukocytosis should always make you suspect bacterial infections. Leukocytosis and neutrophilia can be seen in tuberculosis as well.
Thank you. So now we had done CBC somehow. It was done outside. Patient came with the report, but the symptoms somewhat and these patterns suggest tuberculosis. Now, what is the next investigation of choice to diagnose tuberculosis? Because we are in a country. Chest X-ray. X-ray or sputum smear. There is one more thing, because TB is not the only disease. When you are sitting in the OPD, you need to log everything, right? And it depends on setting where you are working. That is also important. So, if you are sitting in this hospital, then it might be separate investigation. If you are sitting in a PHC, it might be a separate investigation. So, in our setup, what is the next investigation? Chest X-ray, lock कर दें. Dr. Hari will answer this.
Yes, so chest X-ray should be done because it will not only give you the characterization of the lesion, it will also help to narrow down the differential. So, in this X-ray, if you see on the right upper zone, you can see an area of consolidation with some loose air specks within it. Probably a cavitating lesion in the right upper zone. And considering the symptoms and risk factors of diabetes in this patient, she could very well have tuberculosis. But obviously, this is the next investigation, not the diagnostic investigation. So, for definitive diagnosis of TB, always as they say, microbiology is needed. But if you have to go in line, so probably X-ray should be the next investigation of choice.
So, it's very common that we do X-ray first in a patient with chest and pathology. So, what are the X-ray findings which raise the suspicion of tuberculosis in that patient? Cavitation, any sort of cavitation, anywhere in the lung. Unilateral, bilateral, upper lobe, lower lobe, upper lobe. Okay, unilateral, bilateral. अगर कैविटेशन नहीं है तो ट्यूबरकुलोसिस नहीं है, हो सकता है. So again, Dr. Hari to answer this.
So most commonly you can get not necessary that you will get a cavity always. You can just get airspace consolidation, nodules, ill-defined nodules, and X-ray being not so sensitive marker. These findings can be very subtle. And then obviously, if you have to differentiate the findings based on parenchymal involvement or mediastinal lymph node involvement or the pleural compartment. So if you have parenchymal involvement, obviously cavities, nodules, and infiltrates and consolidation air bronchograms can be seen. Sometimes miliary nodules can be seen, like in extremes of immunosuppression, you can get miliary nodules. If you just have a mediastinal lymph node enlargement, then you will just get a hilar prominence or mediastinal widening or widening of the paratracheal spine. So these will be suggestive of a mediastinal lymph node involvement only. These can be with or without parenchymal involvement. And lastly, you can have pleural compartment involvement. So pleural effusions can be one of the findings of which can suggest a extrapulmonary TB, although they may be associated with a parenchymal lesion as well.
Thank you. So these are the X-ray pictures. Okay, now is X-ray sensitive enough to diagnose tuberculosis, or it can be normal in a patient of tuberculosis? Can be normal. How frequently? Place your bets. Dr. Nishant, please.
X-ray is a good screening kind of test, but not very sensitive. So as it's shown here in the slide that 5 to 10% of the patient can have normal X-rays, and the part is that if the patient is very much symptomatic, बहुत ज़्यादा symptom आ रहे हैं उसको, sputum बहुत ज़्यादा आ रहा है, और some V's there, like that sputum and V's है, और आपको normal X-ray दिख रहा है, probably जो दूसरी differential आप सोच रहे हो, maybe asthma, especially in children, आप फिर कुछ और सोच सकते हो. So negative predictive value इसकी अच्छी है, and this is the main thing.
Just I want to add one point regarding pleural effusion. So basically pleural effusion is due to hypersensitivity reaction. Sometimes patient may present only with fever. You may not find any constitutional symptom. Weight is also preserved, and there is no anorexia. And sometimes child is present, means particularly we see pediatric patients. So this pleural effusion we see in adolescent. So adolescent presenting only with fever and pleural effusion. So it is due to hypersensitivity reaction. So you may not find acid means CB net positive or means this pleural fluid might also be negative. Okay. So you need to keep high index of suspicion, particularly in case of pleural effusion. Okay. Then you will send biochemistry and you will be able to make the diagnosis. So in such case, IGRA and MON2 might be helpful.
Thank you. And now, what are the differential diagnosis of tuberculosis on a red X-ray? Pneumonia, variant. Sarcoidosis, okay. Silicosis, very good. What else? NTM may be there. Dr. Gopal, please.
You may say all differentials, but NTM will definitely not be on X-ray. I think the most important differential is naturally the bacterial pneumonias. I think that X-ray is very vague. It is sensitive but vague in cases of tuberculosis. We may find fungal infections, bacterial infections, parasitic infections, vasculitis, malignancies which are cavitating may mimic. We have seen patients, I think many patients with lupus pneumonitis, we initially treated as tuberculosis and then finally they turned out to be lupus pneumonitis. So I think we should keep the arm open. Anything can mimic tuberculosis, right from malignancy to any kind of infections to connective tissue disorders. Fungal infections is something which we are seeing on a higher level nowadays. So I think we should be open to all the possibilities.
During our agency, we were told tuberculosis can cause everything except pregnancy, and it can on X-ray it can cause anything. Any shadow can be tuberculosis. So now, what are the limitations of X-ray in a case of tuberculosis? It can be diagnosed on X-ray. Not confirmatory. What else? At times it can be negative also. So, Dr. Nishant, please.
So, as we all know that X-ray is a two-dimensional image which we get. तो हमारे जो एपिकल एरियाज हैं बिल्कुल एपेक्स ऑफ लंग में या फिर रेट्रोकार्डियक इफ एब्नॉर्मलिटी है तो वो हार्ट आ गया सामने आपको रेट्रोकार्डियक एरिया मिस हो जाएगा उसमें देखने के लिए एंड सम रीजन्स जो क्लेविकल के पास हैं और so small that they are out of resolution of this X-ray. So that can be picked by CT और जब उसका 3 dimensional हम reformatting करते हैं या sagittal section में turn करते हैं, then we get the regions which were missing on X-ray. So this is basically.
I think that this is very important. Just a incident when maternal uncle आए कफ के साथ में and we did X-rays and investigations. Everything was normal. And regarding this intra-reader variability, what I am telling, so we got an X-ray done और मेरे को X-ray ठीक लगा but डॉक्टर निशान थे पास में मैंने एक दिखा फिर उन्होंने कहा ऊपर मेरे को एक हल्की सी शैडो लगी मैंने मुझे तो नहीं लगी ठीक लग रहा मुझे तो X-ray मेरे को एकदम मैच कर रहा है वगैरह नहीं है तो फाइनली बट वी बोथ एग्रीड कि अभी इनको एक बार हम ट्रीटमेंट देते हैं जस्ट रहेगा वो ठीक हो गया एब्सोल्युटली ठीक बट स्टिल ही वाज ए बिट डाउट उन्होंने कहा वापस करा लेंगे X-ray. Then after city में कुछ आया, but still both were not very sure. He was of the opinion we should be giving. I was the opinion not giving. Finally, we didn't give, and he was absolutely all right, nothing. And I was very convinced with myself. बचा लिया इनको टीबी से. टीबी दवाई से बचा लिया. Interpreter objection. But after 6 months, he presented with blue diffusion. मैंने इनिशियली कहा कि एज रिवर्सल नहीं SRCRP रेज्ड नहीं and we should not be. So even in CT we have variations. So what about X-ray? Finally we taped and he recovered. So this is to discuss is very easy. Dealing in real cases is very difficult.
So now the patient, what is the basic sputum investigation to be sent in this case? Sputum what? Okay. Dr. Jagdish, please.
So basically, we are having facility of CBNet. So previously we used to send sputum for acid-fast bacilli, but it has been realized that for detection of acid-fast bacilli, ZN staining is quite cumbersome procedure and you require skilled person. And CBNet with availability of molecular diagnostic test, we are able to diagnose, okay, with less number of bacilli in the sputum. Okay, nowadays expert ultra is also coming, means it's available in few of the centers also. So with this CBNet, we are able to isolate around 131 bacilli per ml. Okay, sputum for AFB ZN staining, if suppose there is multibacillary, there is tuberculosis, then probably you may be able to diagnose. There are one situation is NTM. In NTM, what you will find sputum for AFB in ZN staining might be positive. Okay, but once you will do sputum for CBNet, it will turn out to be negative. So sputum for CBNet will be the preferred choice nowadays. Okay. But yes, for follow-up, we can do sputum for AFB because CBNet may persist even after the treatment. CBNet positive.
Sir, would you go for the ZN stain first and then CBNet if it's negative, or the both the things together?
Actually, if you are doing sputum for CBNet, facility is available, then I don't think there is need for doing ZN staining. Means in pediatric, we are following this algorithm. Dr. Nishant.
So when we discuss about tuberculosis, there is a very important thing, the quality of sputum. What is a good quality sputum? So patient has come with a sample of sputum, how would you say that is a good quality or it's a bad quality? Early morning. What else? 15 ml. 10 to 15 ml. इतना सारा patient निकाल लिया. What else? Dr. Ravi, please.
This is a general question which is good quality sputum. So this is also called as adequate sputum in tuberculosis patients. So the volume of the sample should be 3 ml, more than 3 ml, and it should be the mucopurulent, or otherwise it should be a mucoid sample. And we will do the sputum microscopy. In that sputum microscopy, we will see 10 epithelial cells or another 25 leukocytes in low power field. So then we will classify it as a good quality sputum. Basing on that, we will do the ZN staining. Thank you.
Now, but patient, as we saw in the history, patient is not producing syndrome. So there is no spontaneous expectoration. What is the next step? Biopsy कर ले, biopsy, lung biopsy. ज़्यादा हो गया. What else? Huh? Induced sputum. Okay. And different opinion? Gastric lavage. Gastric aspirations. Children. Okay. Okay. So, Dr. Hari, we explain this.
So yeah, we should ideally do an induced sputum for if you have a predominantly dry type of cough. And induced sputum means you have to give a nebulization with 3% saline, that is hypertonic saline, and again collect the sample, early morning sample. So even that helps to avoid further invasive or advanced procedures like bronchoscopy. So it should be ideally an induced sputum which should be done if your patient is having a predominantly dry cough. And as you said, in children, gastric aspirate could also be useful for that.
So basically, this is the common scenario in pediatric patient where we don't have good quality of sputum. So we need to rely on gastric aspirate and induced sputum. sputum. So in children less than 6 years, they usually tend to swallow the sputum. Okay. So what happens means if patient is less than 5 years, 6 years, then we ask the patient to come fasting for at least 6 to 8 hours. Then in early morning, we insert the nasogastric tube and take the gastric aspirin, and which we send for CBD. So in older children, more than 5-6 years, we tend to do induced sputum. For induced sputum in children, we first nebulize with salbutamol, because sometimes nebulization with hypertonic saline may lead to bronchospasm. Okay. So first we nebulize with salbutamol and then we nebulize with hypertonic saline. And then sometimes we tend to do physiotherapy, because children usually do not expectorate. So we do physiotherapy. Even after physiotherapy, if there is no sputum, then we take the sample from posterior pharyngeal wall by suction. So this is the method which we will follow.
So for a 2-3 years child, there is not much role of reduced sputum.
2-3 years, he will not be able to expectorate. 5-6 years will be able to expectorate after physiotherapy or means, but less than 5 years child will not be able to expectorate. So less than 5 years, better to take this gastric aspirin.
Now, the same question again. So, when should we send a sputum smear? After a negative smear report, or when, or right after? So we are increasing the cost. And does this have an incremental yield? Because if we are doing an additional testing, it should have an incremental yield. आप एक दुकानदारी बंद करोगे क्या? हमारे फैमिली इसीलिए बैठे हैं।
Now it has been extensively discussed and everyone in the room should take this message back home. That once upon a time, not very long ago I must say, we used to rely on sputum smear for diagnosis. Literature says that 2 sputum samples used to yield about 95% sensitivity. But now you know that even chest X-ray is investigator dependent. Similarly, sputum samples or sputum investigations are investigator dependent. That under a microscope, how well your lab technician is trained and can detect AFP. Therefore, the sensitivity based on the field experience is as low as 50 to 60%. Though in literature, 2 sputum samples or 3 sputum samples are quoted as having 95% to 99% sensitivity. Thus, CBNAT is an important diagnostic tool should be offered to patient upfront as soon as you are suspecting TB and planning to send the sputum sample. Though in resource constrained setting, you may have to offer AFP staining, but whenever at district level you are aware that CBNAT facility is available, you need to take this choice of sending the CBNAT sample. Advantages are many. Early diagnosis, the results are available as early as 2 hours. Then rifampicin resistance can be diagnosed. And with the surge of MDR-TB, it is essential to offer patient the treatment in drug-sensitive TB category or the drug-resistant TB category. So CBNAT offers many advantages and any patient should not be withheld from CBNAT diagnosis.
So the message is clear, it should be done upfront. Because the yield is incremental and it gives additional information for the treatment. Now, what is the sensitivity and specificity of sputum CBNAT? Because it's important. If CBNAT is negative, does it confirm that patient is not having tuberculosis, or still patient can have tuberculosis? So, what is the sensitivity and specificity? You can place your bids now. Huh? 190. Or 95, 99. और कोई? 98, And specificity? 100%. Dr. Ravi, please. आपकी जरूरत है.
So in case of pulmonary tuberculosis, the pooled samples that are smear positive, 98% nearly, more or less 98% were sensitive. It is having a high sensitivity. In case of smear negative samples, the sensitivity has been dropped from 55% to 60%. And if you see the specificity in smear negative samples, the specificity is 90 to 95%. So you can always screen both Eden staining as well as the CB9 in parallel, and you can always have that advantage. Okay.
Now, this patient is clinically looking like tuberculosis. We have sent sputum investigations. CB0, the program says the report will be available in a day, but most of the times it is not. So what should we do when we are getting the report? क्या करना चाहिए हमें? CT thorax or no treatment, symptomatic treatment, or everything. We are waiting for the report. Empirical treatment. Dr. Gopal is there for rescue.
I think we are inclined, all are inclined for symptomatic treatment as patient is clinically stable. Naturally, this patient is very stable, but we do not get such patients routinely. So I think that we should be keeping our arms open. I am not in favor of empirical treatment every time, but I think that still, not in this patient, in general scenarios, patient's health and his life is much more important than just establishing the diagnosis. So we must be looking at all the things. If the patient is really sick, if the patient is sick and we are getting other evidences, we should be thinking of CT as well, we should be searching for other things as well, and finally we should be thinking of empirical treatment as well. So I am not an advocate of empirical treatment, but still I feel that patient's life is much more important than our establishment of diagnosis. In this case, it is very stable patient. So there is no issue that we should be treating the patient symptomatically, and we will get the report and then we will decide.
Thank you. Again, Dr. Jagdish, could you please emphasize a bit more? Should we start ATP on empirical basis more frequently, or it should be discouraged?
So I will particularly talk about pediatric patients. Okay. So pediatric patients are having very non-specific complaint. Sometimes child is not eating well, not gaining weight, and they tend to go to private practitioner. And we have seen patients there means empirically when started on anti-tubercular treatment. So in pediatric patients, we are having very stringent criteria to start empirical ABT, as highlighted by Dr. Gopal also, that if suppose patient is critically sick and you have no other alternative diagnosis, then in such case we tend to start empirical ABT. Else we try to isolate, we try to efforts for microbiological confirmation by means of induced sputum, and sometimes we do CT and bronchoalveolar lavage also. So we try every effort to establish microbiological diagnosis, and then we start anti-tubercular treatment. So we found if there is some evidence, suppose there are necrotic node on CT scan, even though CG-NET and other tests are negative, and there are some supportive evidence in form of IGRA or MT positive. So we take these into account, and then probably we may start empirical ATT, even if microbiologically patient is not confirmed. But routine empirical ATT is not justified. So we don't start. Even we have seen few patients, for example, child is coming with pain abdomen in our OPD, and there are degenerative lymphadenopathy of around 5-10 mm. So in such cases, private practitioner tend to start anti-tubercular treatment, but there is no rationale because with any infection, GI infection, there is mesenteric adenopathy. So you need not to start anti-tubercular treatment. So in our country, I think overdiagnosis of tuberculosis is also a problem, and which may lead to development of drug resistance. So we should try every effort to make microbiological diagnosis, and it's also important so that we can also pick up MDR tuberculosis and treat it up.
So, when we were in our residency, we started 20 years back. At that time, it was very common to start empirical ATT.
Yes.
But now, there's hardly countable number of patients we start empirical ATT in a year.
Yes.
So I think we have left that unless patient is sick and there is strong suspicion, we don't start it.
Yes. So I think it's thanks to program, TB program and awareness of doctors.
And improve diagnostics also.
Previously, you are absolutely right. When we were residents, our chief was round. He used to see the X-ray and see this is hyaluronic start anti-tubercular treatment. And once I recall 20 years back, then I realized that most of the patients were having non-specific kind of symptom and might be having some mild respiratory kind of illness and may not require anti-tubercular treatment at that time also. But yes, ATT was misused in the past, and probably with program and awareness of the doctor, nowadays empiric ATT I think people are using less, and I think we should make every effort to make microbiological diagnosis. And even after that, clinician convinced that there is no alternative diagnosis, then probably is the case. But it's very rare.
So, as per Dr. Gopal as well as Dr. Jagdish, it is very clear that empirical ATT should be a reality. When patient is sick, either sampling is not possible and there is strong clinical suspicion, only in those scenarios it should be started. So, her sputum report came after 2 days. Sputum was AB negative. CNAT showed and TB was not detected. So, what will you do next? Empirical ATT, CT thorax, repeat in the sputum, alternate diagnosis, or bronchoscopy and lavage. So, Dr. Hari, please elaborate.
So yeah, I would go with a CT thorax because in our case the differential is not only TB. We have other differentials like bacterial pneumonia or some non-tubercular etiologies or non-infectious causes as well. So better to do a CT thorax to best characterize the lesion and narrow down the differential and plan further investigations. So I would go with doing a CT thorax in this case.
So this is the CT thorax.
So as you can see, the right upper lobe, you have a thick-walled cavitatory lesion with surrounding consolidation as well, with some green but kind of opacities in the periphery. CT thorax now convincing or leading us more towards tuberculosis as the cause of infection in this lady.
So now what is the role of CT in diagnosis of tuberculosis? First of all, is it diagnostic investigation or not? Can we diagnose tuberculosis on the basis of CT? Is there any picture which is specific to TB? Any single picture? Dr. Hari, please.
So yeah, so radiology is only suggestive. A definitive or confirmatory diagnosis of TB is always and always microbiological demonstration of or pathology sometimes in EPTB. So CT is not a diagnostic, but yeah, definitely it is better than your two-dimensional X-ray in characterizing the lesions. And sometimes a lot of investigations like sputum, gene expert may not be widely available. And at that time CT will help us to narrow down the differential and plan investigation further. Like if you have a lesion in the right upper lobe, as in our case, we could, and if the sputum is negative, we can plan further tests like a bronchoscopic lavage, or if there is mediastinal lymphadenopathy, some bronchoscopic procedures like EBUS, sampling of the mediastinal lymph nodes can be done. So CT helps us to narrow down the differential and plan investigations accordingly.
So now, what is the next investigation? CT is also appearing like tuberculosis, but we are not sure. So what should we do now? पीछे से please. CT का biopsy. Biopsy किस तरह की biopsy? कहाँ से लेंगे? Leg muscle biopsy. Leg muscle biopsy. Lung biopsy. ठीक. हाँ. Biopsy. बाल. तुम इन्फेक्शन डिजीज वाले हो क्या? कहाँ से? माइक्रोबायोलॉजी से हो? हाँ, मेडिसिन से हो? So again,
So biopsy is a bit more invasive. There are simpler tests like a bronchoalveolar lavage, which is a relatively non-invasive test compared to biopsy. Biopsy has complications like pneumothorax and bleeding. So bronchoalveolar lavage should be done. Basically what we do is that we pass a thin scope through the nose or the oral cavity, and with the CT you have the anatomical location. So in this case it was right upper lobe, probably apical segment. So what we do is that we take the bronchoscope into a dedicated segment based on the CT location, and we put measured amount of saline, like 50 to 100 ml saline. These are called as aliquots. And once the saline is instilled, we suction it out. So bronchoalveolar, so as the name suggests, you get a proper alveolar sample. So whatever saline has been instilled, it will be representative of the alveolar sample, and that sample which is suctioned out and collected in your mucous traps is sent for analysis, both cytological, microbiological investigations like your CBNAT and AFB stain, and fungal and bacterial cultures as well. So that is called as a bronchoalveolar lavage for diagnosis of ear infection etiology.
Now this is one example. So, and Ball sample was sent for germ stain, CBNAT, NTEP culture, gram stain, aerobic culture, fungal stain culture. And her report came as Ball for Jordan AFB 1+. So, Jordan stain was 1+. The CBNAT was empty detected and no rifampicin resistant detected. So, what does AFB 1+ means? मतलब सबसे बढ़िया वाला बैक्टीरिया, बेस्ट क्वालिटी ऑफ बैक्टीरिया, A class, 1+. हाँ? What does it mean? 1+. Dr. Ravi, please rescue us.
Microscopy, most of our microbiologists know, is the grading of our AFB staining. So, if you see no AFB in 100 IOL immersion fields, then it is called as, after seeing the 100 IOL immersion fields, if it is no AFB is found, then we will report it as a negative. If 1 to 9 AFB are present in 100 IOL immersion fields, then we report it as scanty in our microbiological report, and it is a positive one. And 10 to 99 AFB are present in 100 oil immersion fields, then we will report it as 1+, and it is positive, reported as positive. So 1 to 10 AFB is present per oil immersion field, it is called as 2+ grade, and the number of fields has to be observed is 50 minimum fields has to be observed. And if more than 10 AFB is present per oil immersion field, then the case is supposed to be 3+ grade, and 20 oil immersion fields has to be observed. So in this case, it is after observing the 100 oil immersion fields, it is +1 grade, and it is 10 to 99 bacilli was observed, and it is positive.
But how much time does it take to examine 100 fields?
So it is usually for 15 to 20 minutes it will take per sample.
So if we say our report is negative, we need to see at least 100 fields.
Yes, we have to screen for 100 oil immersion fields, then only you can say that how many fields positive it is graded. Grading can be done after seeing the 100 immersion.
Thank you. And now, how will you interpret these reports? The Jordan stain positive, CBNAT empty detected, no absorption resistance. If stain is negative, empty is detected, but Okay, second. What about fourth? Third and fourth. Okay, sorry. Second and fourth. और फिर क्या करोगे? लंग वैक्स ही करोगे? Dr. Ravi, please again.
So in the first case, in the second case, you can see the Jodpur positive, negative, irrespective, and it is a CB-NAT positive. In vice versa case, you should start with the first ATT treatment, as well as you have to send the sample for the first line of LPA. In the third case, it is a Jodpur positive and CB-NAT negative, and it can be started with ATT. On the basis of clinical radiological findings, means it is a patient is having any clinical correlation, has to be started with ATT and needs to be tested for LPA and as well as culture. In case of Jodpur negative and CB-NAT negative, and it is clinically suggestive case for tuberculosis, then it has to be ruled out for the fungal as well as the bacterial infection first, then the ATT can be started if you strongly suspect a case for tuberculosis.
Case third, I have some different opinion also. Sometimes in Jodpur positive and CB-NAT negative, MTB not, we have NTM, though it's rare, but atypical mycobacterium might be having this kind of situation.
No cardiac type.
Yeah.
So, what is the significance of first line LPA in smear positive cases? First line LPA. Should we do it or not? Or Dr. Ravi again, please.
So nowadays it is the first line LPA is more common because we are seeing the isoniazide resistance more common. So in before the treatment is 12% of the cases have been having the isoniazide resistance, and after the treatment also 25% of the cases are also having the isoniazide resistance. So LPA has to be done once you start the ATT treatment, or starting the ATT treatment. And also important driver for is the resistance to the rifampicin, which is more common in the most of the cases, defaults.
Yeah. So the final diagnosis of the patient is in microbiology confirmed drug sensitive pulmonary tuberculosis. She was started on ATT, 3 tablets are busy per day. So now, what is the treatment of drug sensitive TB as per new NTEP guidelines? For HRE, इससे पहले 2HRZD. Please.
Adopt नहीं किया, इसमें कुछ प्रॉब्लम है.
So we'll talk about NTEP guidelines, not to confuse any of our residents. So the patient is drug sensitive TB, and so based on history, you have to differentiate whether patient is a newly detected TB or previously treated patient. So how you will ask this कि patient का previous treatment हुआ है या नहीं हुआ है? Please be loud. Previously treated TB के क्या हम what history we elicit?
If they have taken medicine for more than 1 year.
So that has to be specifically asked कि अगर कोई भी बीमारी के लिए 1 month से ज़्यादा medicine ली है continuously. So if patient is saying yes, then you have to suspect previously treated TB because the patient came out to be drug sensitive, having drug sensitive TB, so the regimen will be same. Essential thing is that now it is fixed dose combination. Previously there used to be 3-4 tablets, which was a hassle for patient. So patient has to take now fixed dose combination, single tablet, 2 to 3 tablets or 3 to 4 tablets depending on the weight bands. Also important is that these regimens are same as far as the sensitivity of the TB goes, because it is drug sensitive, so all regime either previously treated or newly detected, the regime will be same. Further, जो आप लोग बोल चुके हैं, then intensive phase is for 2 months, 4 drug HRJD, and the continuous phase is for 4 months HRE. In case of severe TB, like CNS, miliary, disseminated, CP need to increase, continuation phase need to increase. And do you recommend doing sputum smear in between? Let's see how this discussion goes on. Thank you.
So just to add on this, previously we were having three means one is newly diagnosed tuberculosis and one was previously treated tuberculosis, and there were means we tend to give streptomycin for 2 months. Okay, in previously treated tuberculosis. Okay, so nowadays there is only one category means even child is having means patient is having new tuberculosis or previously treated case. So you need to send CB9. Okay, if child is patient is coming again, and if patient is drip sensitive, then you will start drug sensitive regime means HRJD, 2 HRJD plus 4 HRE. Okay, so we are not giving streptomycin. So streptomycin is now out from the program. So program is not recommending this streptomycin. And previously, if someone of you might have remembered that we were tend to give only HR in continuation phase. Okay, not E. So E, how we came, because as data showed that background isoniazid resistance is between 10 to 25%. Okay, so suppose if you are giving only isoniazid and rifampicin, okay, and there is background resistance of isoniazid of around 10 to 25%. So you are practically giving only one drug in continuation phase. So there are high chances of development of resistance to rifampicin, which is very important drug for tuberculosis. That's why this ethambutol has been added in the continuation phase.
What about pyridoxine?
Sorry?
Pyridoxine.
Pyridoxine, yes. So pyridoxine, you are supposed to give 10 milligram per day pyridoxine. Okay, 10 milligram per day pyridoxine should be given. Pediatric, we are following this guideline. In adult, we are also giving 10 milligrams per day. 20. Okay. In pediatric, we are giving 10 milligram per day.
Why Dr. Sujit asked for pyridoxine, that it has to accompany the treatment? Definitely, वो भूल भी जाते, but our resident should. That why pyridoxine was added.
Now, what is the dosage strength of FDC and adult grade transport? कितने केजी तक कितने टैबलेट?
ये डॉक्टर सुरजीत को मुंह जबानी है।
I think there are 5 bands, 25 to 39. I think they should have kept it as 40. So 25 to 34. This is the first band. They should kept it as 35 because we usually forget. 25 से 35 आराम से याद होता है. 34 बड़ा अजीब सा लगता है. Then the first is of 10 kgs. I used to remember it like this: the first of 10 kg, then of 15, then of 10, then again 10. The last one, 65 to 75, is 10. The first is 25 to 34. In between, there are 2 bands of 15 kgs, like 35 to 49 and 50 to 64. The last one is 65 to 74, and 75 and more is the 6 tablets. So practically 2, 3, 4, 5, 6, 10, 15, 15, 10. So I think वो ज़्यादा आराम से याद रहेगा. ये सोचना चाहिए कि मैं थोड़ा कॉम्प्लेक्स रखने की कोशिश की तो याद इतना रहेगा कि 25 से लेके 34 हुआ था, फिर 35 से लेके 49 हुआ था, फिर 50 से लेके 64 तक हुआ था, then 65 to 74, and 75 and above is the last band. I think this is easier.
डॉक्टर गोपाल ने निमोनिया के साथ बात किया. So, these are the straight. दोनों स्ट्रेट में क्या डिफरेंस है? additional tests will be done for patients starting on 8:30. हमें कुछ टेस्ट करना है उनका कुछ और भी HIV वेरी गुड पीछे से हाँ LFT और सर किस लिए कराएंगे हार्मोनी के लिए ओके निशान प्लीज
Additional tests. Okay. So once you have diagnosed the patient of tuberculosis, apart from weight and all, because weight band के हिसाब से आपको देना है drugs को, और उसके लिए मैं कहूँगा याद रखने की जरूरत नहीं है ज़्यादा दिमाग पे, आप ग्लास का जो रहता है उसके नीचे आप उसको I keep it stuck on my table लगा सकते हो ताकि दिमाग पे ज़्यादा वो लगे, और ग्लास के नीचे आप रख सकते हैं, मोबाइल पे स्क्रीनशॉट रख सकते हैं. And apart from that, what the government has said that HIV and RBS, diabetes screening should be done in these patients. That is very important. And since एक सवाल मैं पूछ सकता हूँ that will drag me 34.5 kg है तब आप कितनी होगी? That is baseline RFT and LFT, ठीक है? Because these drugs have toxicities, तो हमें देखना है कि baseline ऐसा तो नहीं kidney functions गड़बड़ है, LFT is already deranged. And you are giving these hepatotoxic drugs to him. Apart from that, as sir was told, notify करना जरूरी है जो इस patient को वो नहीं भूलना है कि हमें notify भी करना होगा. So these are basically the major.
Thanks. And so, what is the role of TST and IGRA in diagnosis of tuberculosis? Can we diagnose disease tuberculosis with the help of IGRA and TST? So what do we do with them? Screening for what? Screening of close contact. So if it's positive, what does it mean? Sir.
Basically, one is tuberculosis. One is tuberculosis infection and another is tuberculosis disease. So we should understand the difference between tuberculosis infection and disease. Okay. So mere presence of IGRA and this MON2 doesn't show that child is having tuberculosis, means disease. Okay. So it means patient is having tuberculosis infection, not the disease. Okay. So these might be supportive investigation. Okay, sometimes means if you don't have this sputum positive or a difficult case and your clinical suspicion is quite high, then probably we may consider. But these positive IGRA or MT suggest that patient is having tuberculosis infection, not the disease. Okay, for disease or confirmation of disease, there should be microbiological confirmation. Okay, so this we need to differentiate whether we are dealing with infection or disease. So in this we all might be sitting in India, if we do MT, then more than 50% might get MT positive. So it doesn't mean that all of us require anti-tubercular treatment. Okay.
So as Dr. Ashok Bhargava discussed, now infection may also need to be treated in certain population, although there are some issues. But now for eradication of tuberculosis, we might need to treat the infection also.
So basically we use MT and IGRA in pediatric practice. If suppose any child who is having tuberculosis, so for contact isolation, so first we rule out active tuberculosis, and if between 5 to 18 years child, if MT or IGRA is positive, then we tend to give isoniazid prophylaxis. Okay, isoniazid prophylaxis 10 milligram per kg for 6 months. So as Dr. Naveen told, that currently we are giving isoniazid prophylaxis, which requires 6 month treatment, 6 month daily isoniazid. But program is soon working on isoniazid rifampicin, in which only 12 doses is required, and it should be given weekly basis. Okay, weekly basis. So compliance is good, and means the cure rate means the prevention cure rate is quite good with this isoniazid rifampicin. So there is some pilot studies are going on, and I hope that soon in a year or so it will be available in prevention.
So, when will you repeat sputums via microscopy? Okay. When will you repeat? You have started the treatment. Will you repeat it or not? If repeat, when will you repeat it? Hydrobiology. After 2 months. And the filing. Dr. Gopal, please.
Before that, I would like actually to comment.
And of both IP and CP.
Kind of both IP and CP. I just thought that she told that only IP. That's we will be testing at the end of IP after 2 months to see whether the sputum AFP is negative or not, and then we will be repeating again after the continuation phase after CP.
Thank you.
So here it is very important. Sometimes people tend to send CB net after 2 months. Okay.
So there's a question. Sorry. Should we need to use CBNAT in follow-up case of? हमने follow-up के लिए smear करा लिया साथ में we will doubly sure. Diagnosis में we wanted to be doubly sure. Now is there any need? Dr. Nishant, please.
Actually, normally in follow-up we do not do CBNAT because dead bacilli, we are concerned with dead bacilli. Bacteria may be there, DNA would be there, but it would be dead, so that will pick up a dead bacteria. Okay? So falsely we will be alarmed unnecessarily, KBB case positive. So it should not be followed normally in these cases, and culture is the gold standard to be followed. अगर आप कर सकते हैं, अदरवाइज स्पीयर पॉजिटिविटी अगर आपका पहले 1+ था अब 2+ हो गया, इट मींस देयर इज सम ग्रोथ दैट विल बी देन CBNAT से हम फॉलो नहीं करें.
Thanks. Thank you, Nishant. And there's no need to follow. Now, after starting treatment, she gained 6 kgs in 2 months. It shows our diagnosis is right. Now, whether her course of treatment should be continued in the same weight band or we should change it? कितने लोग चेंज की फेवर में? हाँ? और कितने चेंज नहीं करेंगे? 47. Dr. Nikki, please.
So, as you know that it is weight dependent dosage. So if the weight has increased, you need to change the dosage schedule. Like 3 drugs, 4 will now go to 4 drugs. तो डॉक्टर गोपाल ने बहुत अच्छे से आपको निमोनिक दिया. So you need to monitor the weight, which we said कि baseline पे लेना है. But as the patient is coming for regular follow-up, monitor the weight and accordingly adjust the dosages of the intensive phase or continuation phase, that how many tablets need to be advised.
Okay, so we are going to change the weight band. Okay. So now her sputum AFP at the end of 2 months shows scanty AFP. Earlier it was 1+, now it shows scanty. So what are we going to do next? अभी भी पॉजिटिव आ रहा है तो MDR का ट्रीटमेंट स्टार्ट नहीं करना? हाँ? IP will continue. No escalation of treatment. Anyone for escalation? Anyone for MDR testing? Continue same treatment. Okay. Dr. Niti again, please.
So now this sputum is positive at the end of 2 months, and like I just would like to now highlight that why we keep forcing our residents to buy updated books. And don't take books from seniors and read it, especially when it comes to programs. Because previously RNTCP guideline was that you extend IP phase if the sputum is coming out to be positive. But now in NTEP, it has changed that even if after end of IP phase, the sputum is coming out to be positive, the continuation phase will start. So you will start the patient on 3 drugs, HRE, and you will stop JED. Then, because now you are also worried that patient has not become sputum negative, so you need to go for extra investigations. So what will be those investigations? Chest X-ray and drug sensitivity testing, right? So these additional investigations should definitely be ordered, as our panelist said that CBNAT has no role, but other investigations definitely have a role.
So basically, when we are following the patient, it is not the investigation, but we should also follow clinically. As Dr. Naveen highlighted, patient has gained 6 kg of weight. So means patient is doing well. Okay, and there is scanty sputum. So there are rare chances that patient might be having this MDR tuberculosis. So yes, DST should be done if you are suspecting DST, means MDR tuberculosis. But in this patient, there is scanty sputum has decreased. So I think means continuation phase may be started since patient is recovering well. So patient may get continuation phase.
And one important thing we forgot to mention when we are discussing the system of one institute. So do we get the CBNAT LPA report in HIS? Next ID. And right now there is no integration of Nikshay with our HIS. So at times what happens? The clinician has sent the CBNAT and LPA, then they don't get the report because they have not opened the Nikshay panel. So it's very important if we are sending a report, the test of a patient, the report will be available on the Nikshay portal. And the ID and password is available in each department because you send from there only. So the report needs to be checked on the Nikshay portal only. Now, so we are treating this patient is going in the right direction, but why do the treatment fail in certain patients? So we have seen the resumption was sensitive. So still, even in such type of patient, ultimately patient lands up in the treatment failure. Why does that happen? What are the main causes of treatment failure? Compliance, very good. What else? New mutation, okay. Other drug interfering with the treatment. What else? Program of supplying treatment regularly. What else? OCP use, very good. Dr. Niti, please.
So, we might have multiple reasons, but we will now just simply try to understand the reasons from program aspect. That treatment is failing, so what we will suspect is emergence of drug resistance TB, or patient might have got MDR TB, and that is because of certain concerns related to counseling of patient, and that counseling was not well enough, patient was not oriented enough, and patient interrupted treatment, started feeling better, कि symptoms तो resolve हो गए हैं, अपने आप दवाई बंद कर दी. At times, when private practitioners, they are treating the patient, so there is a factor of cost attached. So, वहाँ patient might micromanage their own treatment, कि अपनी मर्जी से वो कभी adhere करते हैं treatment या नहीं करते, and they may interrupt on their own. Or private practitioners, because they are not well versed with the weight band and the adjusting of dosage according to weight band, so it has been seen that inadequate dosages are prescribed. Other than that, there could be many other reasons also, but when you are sitting in a OPD, try to address all these reasons when you are counseling the patient, that interruption of regime, poor adherence could be minimized as much as possible. Sir?
I want to add. See, my question is like, this is a real patient with one of my relatives only. Like it's the second point which is inadequate regimen. Like most of the private practitioners are not well versed with the updated guidelines. See, here we also see, like Dr. Niti was saying, like we should continue with the continuation phase, and some of the residents are saying, yeah. But at the end we find out continuation phase should be, IP should be stopped and started with continuation phase. One of my relatives was started on, like patient was of no rifampicin resistance, and because the patient was not able to tolerate isoniazid for some days, so the patient was started on very new regimen. It is designed by that practitioner only. It was ethambutol, pyrazinamide and levofloxacin. There was no isoniazid and there was no rifampicin. So that is why I think like so much modulation of regimen should not be there. They should be well versed with the regimens. Inadequate regimen is one of the main causes of failure.
I would like to add one point, sir. Rare but important. Even if I have seen 2-3 cases, you have ruled out all these factors. There is one thing, that is therapeutic drug monitoring of ADD also. There are certain labs which do the levels of these drugs. So I have seen 2-3 patients, in spite of doing everything correctly, still patient was not getting cured. We got the levels done from a hospital in Mumbai, Indian hospital does it. And surprisingly, all the levels were low. So the dosage had to be stepped up. So you must have got fast acetylator, slow acetylator. The metabolism of the drug also varies in certain rare patients. So keep this at the back of your mind that some things like this can also be looked at.
Because we
So-
must come in faster.
Yeah. So one real life example I would like to give in our OPD. We are following TB patients in TB clinic. So one patient, as you all know, that few of the patients might require PPI because they are having they had severe gastritis. Okay. So what happened? One patient who had severe gastritis with this anti-tubercular treatment, we prescribed PPI and asked the patient to take empty stomach. Okay. And after 2 weeks, we asked the patient to come for follow-up. So it's very important to check the drug on each follow-up, whether patient is taking adequate dose or not. So after 2 weeks, when patient came, we were surprised that patient was not improving. Okay. When we asked the patient to show the drug, patient कि आप खाली पेट दवा ले रहे हो? Patient ने बोला हाँ खाली पेट दवा ले रहा हूँ. We showed that patient was taking anti-tubercular treatment. But what patient did? Patient stopped the anti-tubercular drug and patient was taking only PPI. Okay, so this might be real life scenario. Okay, so it's important to ask the patient to bring the drug and confirm whether patient is taking adequate dose and drugs in adequate dose or not. So this is also very important when you are following up TB patient.
So there are so many causes of treatment failure. We need to take care of them when we are treating the patient or we are following the patient. So now, can we add levofloxacin to this patient as he is sputum positive at the end of life? So it's scanty positive, so we need to escalate the treatment, isn't it? Dr. Nishan, please come to our rescue.
This is mentioned that baseline fluoroquinolone resistances are approximately 20 to 25% in patients. But one golden rule of anti-tubercular therapy, one of the golden rules of anti-TB therapy is do not add a single drug to a failing regimen. That is one thing. That is one of the background reasons why streptomycin has been showed off this table. That पुराना treated है तो streptomycin start कर दिया जैसे कि पता नहीं क्या हो जाएगा उससे. Was failing. So एक drug के भरोसे तो रहते हैं. Same goes for levofloxacin also. So you should be very careful and reserve this drug for a drug-resistant tuberculosis when confirmed.
Thank you, Nita. Now, she completed 6 months of therapy. 2 months smear was negative. Now the patient is cured, right? So, do you still want to follow the patient for 2 years? That's a long time. Huh? Okay. Any difference in opinion? Sir, please.
So usually we follow the patient up to 2 years. Okay. So after completion of anti-tubercular treatment, we ask the patient to come for every 6 months or 2 years at least. 24 months.
So many times we see the patient they improve and again after some time they again become symptomatic and they are again later with pulmonary tuberculosis. So what is the incidence of relapse of tuberculosis and what measures should be used to prevent the development of tuberculosis? हमें पता है कि एक बार ट्रीट करते हैं तो पेशेंट को दोबारा होने का चांस रहता है ना, तो हम पहली बार ही जब ट्रीट करते हैं तो कोई कुछ यूज कर सकते हैं? Any precaution? Anyone? Fancy pattern should be. We should treat according to that way. Right? What else? Dr. Neeti, please.
Incidence of relapse of TB is अच्छा इन्होंने किसी ने भी कोई आंसर नहीं दिया ना, right? Okay, so incidence is quite, the range is quite wide. So relapse of TB as a primary अगर resistance है, so it could be around 3 to 4% what international literature says, but in Indian based study it has found to be as good as 10%, and in case of previously treated cases or treatment after default, then the relapse could be as high as 24%. And I would like you all to tell me what are the ways to prevent relapse, because now I think we are nearing the end of the session. So how to minimize the relapse?
Follow the guidelines and treat the patient as well.
So one major take-home message should be ensure completion of treatment. That what every one of us is trying to convey from this platform, that patient need to be monitored and asked about the drug compliance at every visit, that whether patient is taking all the drugs and in adequate dosage. So completion of treatment and monitoring of patient even after the treatment has completed, so that like at least for 2 years, and if not possible at least for 1 year. And then taking care of the risk factors. So previously we have seen there are many patient-related risk factors, like if patient has diabetes, HIV, comorbidities. So in all these scenarios, you have to monitor more closely, and patient need to be treated for comorbidities. And I think one major thing which need to be considered is nutrition. That is across socioeconomic status. Poor nutrition or malnutrition is across socioeconomic status. So ensuring good nutrition in these patients can prevent relapse.
So you have diagnosed the case of tuberculosis, the way we diagnose this. So now, normally what happens? We diagnose a patient, we treat the patient goes home, that's it. But TB is a notifiable disease. So what else do we need to do? Abhi to you are working in hospital. So tomorrow you will open your clinic. So how will you generate the ID? From where you will register for the portal? Please.
So, TB notification is now essential as per, it is like mandatory as per gadgeted notification, and it was done somewhere in 2018. in March 2018, a year before we suffered COVID. So though notification is still poor, but there are many players who are supposed to notify TB case. Other than health practitioners, who else you think are important while we are considering notification of TB cases? Yeah, so as you know, microbiology has a huge role to play. So laboratory facilities, then pharmacist, chemist. So all of these have been entrusted with the responsibility of notifying TB case as and when they are dispensing drug, testing the patient for TB, along with health practitioners who are treating. And in case they fail to notify, do you think is there any concern attached? Like some busy practitioners may say that we are too busy, like morning till evening we are running OPD, we don't have time to notify or fill reports. So they are booked under negligent act of allowing a dangerous disease to spread. So the punishment is till 6 months jail and some heavy fine. So this is essential to remember that it is not a choice, it is mandatory.
So one is we can penalize if we don't notify it. So is there any advantage of notifying the disease to the authorities? Benefit to the patient or the doctor? Money will come. Money will start flowing. The way we do Lakshmi Puja. Notification is next Lakshmi Puja. Dr. Niti, please.
As you know, that whole program core strength is early identification. So TB notification will help not only to trace the patient, give them certain support in terms of nutritional support, which Dr. Ashok Bhardwaj very categorically mentioned, that patient will start getting direct benefit transfer of around rupees 600 or 500 per month. And for a poor patient, it is a good amount to ensure some sort of nutrition. And in case patient is treated for 6 months, so he is getting 3,000 rupees. So other than that direct benefit transfer, it is also to ensure to take care of comorbid condition, for early identification of household contacts. And now you know if there are household contacts, we need to start prophylaxis, AIIMS prophylaxis. So there are many steps attached. Once a TB case is notified from a health facility or from any pharmacist to the system. So once you notify a case to district authorities has a huge list to take care in such scenarios. And what is the benefit for practitioner? So there is a nominal incentive attached, like in terms of 1,000 rupees per patient. So 500 when they notify a patient and extra 500 when the treatment is completed. But what we are doing is essentially preventing a dangerous disease to spread and chances of resistance emerging in long run.
Thank you. So the take home message from our panelists for this discussion. Just quick one lines. Whatever we have enumerated few, but you can have your own.
I think the first line is very important. Microbiological diagnosis in tuberculosis is very important. So it will also help us to know about drug-resistant tuberculosis. I think first of all, awareness about tuberculosis in general public, in clinicians is very important. Many times we miss the diagnosis, even experts miss the diagnosis. I think it is very essential to know that tuberculosis can present in any way, and we should not always be looking for typical presentations. So I think it is very important to keep this diagnosis as a priority. Even though we are practicing, we tend to miss it.
So my take would also be similar, but only thing is that I would, at medical college level, one should always make an effort to achieve a microbiological diagnosis as far as possible. Empirical treatment should be avoided as far as possible, because drug resistance is a major challenge, and we should always rule out drug resistance upfront so that we treat the patient properly and the outcomes are also better. So that would be my take.
I would recommend at last that once you come across a TB case, notify. Because that is not only the patient, it is the whole range of responsibilities to be taken care by the district health system once anyone gets TB. So notification is mandatory. Thank you.
Thank you all. There's a lunch waiting for you downstairs. Have you seen the cafeteria?
Naveen, I think we should have a group photo.
Group photo.
Yeah, अभी और कोई questions हैं तो
Any questions?
question है तो ले सकते हैं हम।
Any questions? Leaving the venue of dinner, lunch. Any questions?